It is indeed a pleasure to be with you this morning as we join to celebrate World Tuberculosis Day 2017.
I bring greetings from Sir Ganga Hospital for all of you. Today this morning we are going to celebrate World TB Day. And I must thank the management of SGT University to give me this opportunity to be with you people today morning. Tuberculosis is a very old and a very serious problem, especially for our country. And let us see what has happened to this disease and this bacteria over years. What is the tuberculosis status today? How was it yesterday? And what do we think, what do we expect for tomorrow? I will be dealing with the timeline of the disease, how it affects a human being, how do we diagnose TB, how do we treat this disease, how can we prevent this disease, and what is the future of tuberculosis in the world and also in our country. Way back in World War II, TB killed more people. Today, the magnitude of problem is very high. 1/3 of the world's population, which is a very big number of people, is thought to be infected with TB. Infection doesn't mean that it is active TB, but some time or the other, TB bacteria has entered their system. New cases, they appear in 1% of the population. So if we have 100 people, one will get TB infection out of 100 within 1 year. And in developing countries, the load of disease is very high, and 95% of the deaths due to this disease, they happen in developing countries like ours. In India alone, every year, more than 2 lakh people die of tuberculosis, and major amount of money in the budget goes in handling this disease in this country. Have a look at WHO data, which says that India is a country which has burden of tuberculosis, which has burden of multi-drug resistant tuberculosis, which also has a burden of HIV and tuberculosis. Many cases all over the country, they are seen in our country. A lot of TB is there in our country, so we have to know about it. How do we deal with it? Worldwide, the incidence of TB is 9.6 million. India alone has 2.2 million cases. Worldwide, 1.1 million people die of tuberculosis, and India alone more than 2 lakh people die of tuberculosis. It's an ancient disease. Long back, ancient mummies, we have seen TB present. We have seen TB bacteria with the help of latest diagnostic tools like PCR. We have found TB bacteria in the bones of these old Egyptian mummies. So it's a very ancient disease, and it is not living human beings till date. It used to be called by various names like consumption, phthisis, Pott's disease, white plague, because it used to consume people. There was no cure at one time. It was a death warrant. So people used to be scared. Anybody who caught TB was sent to hills because there was no treatment, and they never came back from the hills. This is a brief timeline of tuberculosis in the world. Very ancient disease. 400 BC, Hippocrates described this disease, clinical features. But at that time, one was not clear whether it is a genetic disease or whether it is an infectious disease. But later on, they understood that it is not a genetic disease because the patient used to cluster in a home. So they thought it is probably a genetic disease. But the first step in the treatment of tuberculosis was to know that it is not a genetic disease, it is an infectious disease. Robert Koch, the father of tuberculosis, found out that which bacteria is causing this disease, and also 1921 a vaccine came into picture, BCG vaccine. Till date, BCG vaccine is being used to prevent tuberculosis, but it is not an ideal vaccine. It doesn't actually prevent tuberculosis from happening, but the scientists say that you still give it because it will not give a very serious form of tuberculosis. Then comes the time when the treatment of tuberculosis came. 1944, streptomycin was discovered, and this was the first treatment offered. Before that, there was no treatment. All the patients who developed tuberculosis used to die. After streptomycin came into picture, isoniazid. At that time, the treatment was for 2 years, and the success was 50%. Today, we treat tuberculosis with 4 or more drugs, and the success is more than 98%. At that time, the treatment was long. Today, the treatment is very short. It is called short course chemotherapy. Later on, TB became more challenging because the bacteria started developing resistance towards the given medicines, and a global emergency was declared by WHO. And now we are in an era where we have lot of multi-drug resistant cases. In Delhi alone, the incidence of multi-drug resistance is in the tune of 5 to 10%. That is, if you see 100 patients of tuberculosis, there is a chance that 10 out of them may not respond to the usual TB drugs. You will have to treat them with some different drugs, and the cure rate in MDR-TB is less than 50%. So people who have drug resistant tuberculosis, 50% will never get cured. They are waiting to die. So it's a very, very, very serious problem, especially for the health workers who are treating patients who come to you, you don't even know whose dental cavity you are treating. Maybe that patient has MDR-TB. So you must take all the precautions. I will tell you how. So from a time where TB patient was sent to Indian sanatorium from Europe to spend rest of the life, now we have come to a time where we say tuberculosis is curable and preventable, but with certain conditions. TB is caused by this rod-shaped bacteria, which is gram positive. It can invade any structure of the body except hair. It can involve anything except hair and nails. The transmission is through aerosol route. Any person who has TB in the lungs has a cavity of loads full of TB bacteria. Even while breathing, this patient is releasing thousands of bacteria in the air. When the patient coughs, millions of bacteria they released, and if somebody is not careful with a mask and is taking these dental procedures lightly, then there is a chance that he will inhale these bacteria and become a case himself. It is more seen in working males In the productive age group, it is lesser in females because they are mostly in Indian rural places, they are confined inside the houses. As I told you, TB can involve any structure of the human body from the brain, where it can cause meningitis, which is a very dreaded condition. It can cause brain abscesses. In the oral cavity, it can cause lot of oral ulcers. It can cause lymph nodes. So whenever you examine your patient, always try to look for any visible lymph nodes. If you find any, then suspect tuberculosis, or at least something abnormal is there. Have a look out on that. It can affect the lungs, it can affect any gland in the body, it can affect the stomach, intestines, bones, joints, genitourinary system, anything. Even the skin like this. So you have to be, as a doctor, you have to be at a lookout that if the patient is emaciated, weak, old, has fever for many days, be on a lookout. Maybe this patient has tuberculosis and you can detect a case of tuberculosis. Diagnosis is made by the symptoms, obviously the medical history, and various TB tests, X-rays, sputum examination or examination of the pus, etc. The main symptoms with which TB bother you are cough, any cough which is more than 2 weeks, not getting relieved with common medicines, with fever, especially in the afternoon or at night, or anybody who has cough with blood-stained sputum. This patient has a very high chance of tuberculosis. Whenever we find a patient like this, we always ask for sputum examination if the patient can produce, and send them for these tests, which are smear and cultures. We ask the patient to go for a MON2 test or tuberculin test, and then go for advanced tests like cultures of the bacteria from these samples, oral samples like sputum or secretions from the oral cavity. We go for X-rays and CT scans. These are typical X-rays of a TB patient. Here in the first patient we have a cavity. You can see a hole in the lungs. This lung on the left side is normal, whereas the lung on the right side has a large hole, which is technically called a cavity, like dental cavities. You have an infected root. So this also has fluid in it. So this patient is likely to have tuberculosis, and it is highly infectious. On a CT scan, you will see a hole like this, and most of the patients, they bleed through this hole and they are highly infectious. We call them open cases of tuberculosis. This is a CT scan which shows these nodules, small dots all over. This is a blood-borne tuberculosis which has gone into the lungs of the patient, and you can imagine how many million bacteria must be there. These are the various common tests available all over to examine the samples of sputum under the microscope, and you look for these rod-shaped TB bacteria. You can even culture these TB bacteria in these tubes and have these kind of colonies. They are very important to detect multi-drug resistant tuberculosis. In advanced laboratories, we have more sensitive microscopes like these, which can pick up these fluorescent spots easily. Anybody can do this kind of microscopy and detect TB cases easily. More advanced technologies, because I told you out of 100, 10 people are not going to respond to your treatment. We have to be on a watch out for resistant cases, and this is the machine which can tell you that which patient has resistant bacteria inside, and this is called a BACTEC 460 radiometric culture system. It is not something which is available in big hospitals. It is available now in every place. Even small laboratories, they have these kind of equipments to tell you that your patient has resistant tuberculosis or not. Other tests like the Montu test you must have commonly come across. Patients are injected with tuberculin antigen, which is called the PPD, like this into the skin, and we measure the reaction. This is the PPD is part of TB bacteria, which is purified protein derivative, and at a particular strength, that is 5 tuberculin units, it is injected in the subcutaneous tissue like this, and then we measure the response after 48 hours. And if the response is more than 10 millimeters, we say that patient is tuberculin positive, and there is a high chance that this patient is suffering from tuberculosis. But this is not a sure shot test. The sure shot test is the sputum examination, wherein you can see actual TB bacteria. There are other tests also which are available, which need not, they don't need injection of this tuberculin. They just examine the blood of the patient. These are available all over the world, especially in developed countries like America and Australia, Europe, where they want to know whether the patient has latent disease or active disease, because they want to treat those patients also where the disease has not yet become active. I will come to that in the later slides. These are also very simple mechanisms in which we put the sample like sputum or pus, and then it is an automated machine. This gives you answers. You don't have to see the slide, you don't have to do anything. It has indicators. It will tell you whether TB is there in the given sample or not. They are so easy that one of these ministers himself attended few lectures and became a good technician. There are other tests you must have heard of. These are ELISA tests. They used to be done 15-20 years ago to diagnose TB, but the new research says that they are of no use. So doctors now, they are not using ELISA technology, and even to the extent the National Revised TB Control Program says that it is a malpractice if somebody is getting ELISA test to get diagnosis of tuberculosis. There are certain new technologies which I am very fond of, because I work in a tertiary care center, Ganga Hospital, and we do all these bronchoscopies. I will just show how a bronchoscopy can give you a diagnosis of TB, where the sputum is not enough. The patient is not producing enough sputum, but he has X-ray picture of lookalike TB, or he has symptoms of TB. Then we do this test. This is the airway inside. Through a bronchoscope, we are going inside. Inside we know which part has TB, and in the bronchoscope we also have ultrasound, and you can appreciate that this is the ultrasound happening inside the lungs of the patient, and we can see these lymph nodes, like the lymph node you see on ultrasound, which is done for the abdomen or for the chest or for the neck of your patients. We can do the ultrasound through the bronchoscope also. That is called endobronchial ultrasound. You take samples from there and diagnose your cases. So to summarize, the natural history of TB infection is very important to understand. If anybody, as a doctor, as a family member, colleague, gets exposure to TB, for example, anybody of us gets exposed to TB patient, we came to know about it maybe 10 days after that. So what is happening inside the body is very important to know. In 70 to 90% of the times, you may not get any infection, but there is a chance that 10 to 30% chance that you have taken in the bacteria and the infection has started. Out of these 30%, 90 will have latent disease. It will never bother you throughout your life. It will remain silent, latent. Whereas 10% will become active like these and spread the TB to other people. Now, if we don't treat them, we feel that this old man has become old and is coughing because of the old age, is having fever, then this patient is going to die within few months. So it is very important for a doctor to understand the difference between latent TB and active TB. I told you latent TB is something which is not become active, it is silent inside. So the patient will not have all these features, whereas active TB patient will have fever, will have cough, etc. So you have to have differentiation points between these two, and if you find that your patient is having active TB, from this chart you can very well understand that anybody who has cough, anybody of your patient who has cough for more than 2 weeks, be watchful. Send the sputum examination, 2 sputum smear for AFB ZN stain, and if they come positive, start treatment. If they are negative, give antibiotics, call the patient, review the patient after 2 weeks. If the symptoms are persisting, go for X-ray. If X-ray shows a patch, then investigate whether it is TB or not and treat accordingly. Most of the TB is curable, but the fundamental principle in the treatment of TB is that you have to use 4 drugs at least. Like simple bacterial infections where we use 1 antibiotic, for TB you have to use 4 antibiotics to start with, and that is called intensive phase that must last for 2 to 3 months, and then we go to continuation phase, and the total treatment is 6 to 9 months depending on the response of the patient. Patient should be instructed to be in isolation because it is an infectious disease, to be in isolation for at least 2 to 3 weeks. He should wear a mask all the time while he is with the family. There is no need to separate the utensils and wash the clothes separately, but the patient must wear a mask. Usually the patient becomes non-infectious within 2 to 3 weeks. The goals are very simple: to decrease the mortality, to prevent development of resistance. If patient doesn't follow the TB medicines properly, then he will become a drug resistant case. So the goal is to tell the patient clearly that this is a treatment which lasts for a longer time. You have to be watchful, you have to take the treatment regularly. All these things are very important for you. As a doctor, you have to tell your patient whenever you are in contact with a TB patient. You may feel that we are doing dentistry, we are becoming masters of dental science. So where does we ever have a chance to meet a TB patient? No. Your patient may be having TB. He comes to you and tells you that, doctor, I am on TB medicine for the last 2 months and now I need a dental treatment. Since you are now clear that the TB patient becomes non-infectious after 2 weeks, you will not be scared. Earlier, anybody would say that I have TB patient, I am taking medicine regularly for the last 2 months, you will get scared. You say, come for dental treatment after a while, after you are declared cured by a doctor. So now you are clear that a patient become non-infectious within 2 to 3 weeks. You are safe, you can do dental treatment and take precautions of wearing a mask. These are the various regimes. I am not going to go into the details of this. These are the various pathways. You must be learning pharmacology, where bacteria are attacked on various domains and they are killed by the various medicines. But if you don't give your patients regular treatment, proper drugs for the treatment of tuberculosis in a particular dosage, then the drug resistance is going to appear. And as a doctor, you must understand the importance of drug resistance. You must counsel your patients. Whenever you come in contact with your patient who has TB, must try and counsel him that the treatment has to be completed properly. There are various names given to drug resistance like mono-resistance, poly-resistance, multi-drug resistance. They are of no value, because once you start treating, then you should know about it. There are different medicines altogether for the treatment of drug-resistant cases. They are not the common rifampicin, INH, parazinamide and ethambutol, but there are injections which have to be injected 5 to 8 months into the patients. There are medicines which are very toxic, which needs to be given for 2 years. So if you have a knowledge that I have to be watchful, anybody who is saying that, doctor, I am having fever, cough for more than 2-3 weeks, if you have a high index of suspicion, or any patient who comes to you and take history that I am on TB medicine for the last 2 years and my TB is not getting all right. So in these patients, you must know that there is an entity called drug resistance. This patient is maybe having drugs. Refer the patient to a physician so that he can treat the patient, make sure that he is not having active TB, and then he comes to you for the dental treatment. Otherwise, you are also at a very high risk of catching the disease. These are the various pathways which the second line TB medicines, which we call when we give it to resistant cases, they affect these pathways and kill. There are so many side effects which can happen because of TB medicine. You have to be aware of just 2. One is they can cause severe jaundice, and the second is they can cause blindness. Any person who is on TB medicine is feeling decrease in the visual acuity, must get him examined immediately, because the vision can go permanently. Anybody who is on TB medicine starts vomiting or develops yellow discoloration, is getting jaundice due to medicine. It can be fatal, so you be watchful. These things are really very important. As a doctor, you will have so many patients coming to you with these symptoms on medicines, and you should know a little bit about this disease. It is still not it is preventable only by in terms of exposure, but there is no real vaccine. All of us, we get BCG vaccination right at birth. You must have seen a scar here on the left arm. Everybody has a scar because everybody is injected with this BCG vaccination right at birth. But it is not a gold standard still. One can get tuberculosis. So we need to have a perfect vaccination. Till date we haven't found a perfect vaccination. And the future, we should have tests to rapidly diagnose tuberculosis. We should have better drugs so that we eradicate tuberculosis from the world. We should have better vaccine so that this disease doesn't happen at all. So in the future, because we are getting exhausted with the current TB medications, we have got many medicines in the pipeline. Many of them are in phase 3, and the treatment of multi-drug resistant tuberculosis is also likely to become simplified 6 to 8 months in the coming years. So we have a hope for the future. Vaccines also are in pipeline in various phases of studies, and we are now near a good vaccine which can prevent tuberculosis. There is a TB strategy by Global TB Program which aims at reduction of tuberculosis deaths by 75% by the year 2025, and they also aim at reducing the TB incidence by 50%, and they aim at major tuberculosis control by the year 2035. India is also doing a lot for its population. They have various programs going on in a very active manner, where they provide you free diagnosis, free treatment in all government center tuberculosis hospital and in many private sector hospitals also. So anybody we find has TB should be referred to these centers for a proper care. With this, I thank you all for your patient listening, and we together can achieve this aim of eradicating tuberculosis from the world. Thank you so much.